Hello, everybody, and welcome again to a Taylor Tuesday. I'm your lovely, talented host, Mike King, filling in tonight for Dr. Krause, who is busy and off doing other things. But we're excited to have you all here tonight, and really excited to have a Australian colleague of ours, Dr. Paul Graham, to give us a presentation tonight on the evolution of foot orthotics, orthoses, and incorporating data into your orthotic design. So it's going to be very, very exciting. So as you know, we always begin with our opening to remind you that you can see or review this webinar again simply by going to taylormedical.com, clicking on webinars, and you can pull this down and be able to look once again and see the great presentation that Dr. Graham is going to give us tonight too. You can also look back and find previous webinars that we've given so that you can glean the information from all these super experts that we have been so fortunate to be able to get. And I know that Dr. Graham, for a change, is happy because he is coming live from Australia, and it's about 10 o'clock in the morning for him on Wednesday, as opposed to us making him get out of bed at 3:30 in the morning. So it's a treat. We're thrilled to have Paul with us today too. So let's just remind you all that if you have not sent in your data to have an analysis done by Carla and team, please do so. Take a look at the products you're ordering. I know that recently we've had rebates go out, and we've had some shareholder dividends, and it's been a really exciting time. And that growth in Taylor is because of all you guys, and we're very grateful for that. For those of you, if you haven't taken advantage of this yet, it's time. Look up your data, pull down your supply lists, your vendors and SKUs, anything you can, units of measure, pricing, and put it on an Excel sheet or however you can get it to us, and send that over to admin@taylormedical.com. Or you can certainly go to the website and you can see the site on here and get a complimentary analysis. So we are super excited about that and about our speaker today. So our speaker, Dr. Paul Graham, is a podiatrist in private practice since 1987. You are a young guy, Paul. With a special interest in musculoskeletal conditions, the focus of Paul's practice has always been on the comprehensive and evidence-based examination and diagnosis of underlying causes of presenting symptoms to achieve the best outcomes. And I'll tell you, Paul, what a evidence-based medicine and things like that in podiatry are just so needed. So I'm excited to listen to this. And in 1998, Dr. Graham first began using computerized plantar pressure measurements. Another big deal come up here, Paul, is with RPM, or remote patient monitoring, becoming a big thing in the United States at this point. So Paul's been using this computerized plantar pressure measurement added to a video examination to evaluate functions and gait, etc. So I'm going to stop this slide presentation. I'm going to let you do yours. I'm going to turn myself away. And Dr. Graham, you're on.
Okay. Well, thank you, Mike. Thank you, guys, for having me. And hopefully I'll be able to present something that'll be really of worth and interest to you. And at the end, I'm happy to answer any questions you might have. So let me share my screen and we can get on with it. Okay. Okay.
We've got you good, Paul.
Okay, thank you. All right, so the title, The Evolution in Foot Orthotics, could mean the history and the process of how we got started using orthotics in the first place. Or it could mean the process of gathering information to inform us of the features that are required in the design of the orthotic prescription. And it is that definition that I'll be focusing on today. So in the late 1990s, I decided I needed an objective assessment tool that I could measure and compare to give me confidence in my diagnosis and treatment. I started with a tethered in-shoe system, but really didn't know exactly what to do with the data it presented me with and how that would affect my orthotic prescription and design. I was very fortunate to have people like Howard Dannenberg, Nicholas Soul, Bruce William, and others helping me along in my learning journey in clinical plantar pressure analysis. And I guess I'm presenting as a clinician rather than an academic on how to use the information presented. Now, everything I say is backed up with research, but it's much more of a clinical point of view rather than an academic presentation. Over the period of time, I've used 3 different systems, and all high speed and high definition systems will provide you with good data to analyze. Some are better for research and their software is designed for that, and some are better for day-to-day clinical use by presenting data to give the clinician the information they need quickly and easily. So long as I said, they're high speed and high definition, the plantar pressure information is very, very similar. I use at the moment the sensor Medica system, which has a great software system that provides an ease of analyzing. All right, so I'm sure we all know about the properties of gravity and the resultant ground reaction force based on Newton's third law. For every action, there's an equal and opposite reaction. What is important to understand is how our body weight is transmitted into the ground and how the ground reaction force acts on the foot. For if the foot's auto-supportive mechanisms are overwhelmed because of dysfunction or are not stable enough to resist the ground reaction force, the most common thing we see is excessive pronation and tissue overloading. We also know that our body weight is primarily transmitted through our skeleton, which in turn is supported by connective tissues, allowing the forces to be dynamically shared during movement. When this works well, the system is incredibly efficient due to the energy store and return cycle. When our skeletal structure is substantially misaligned, or joints, muscles, or connective tissues are not functioning well, tissues can be overloaded and become injured. So we have a look at this tissue stress model, giving us an understanding of how people become injured. And what I'm going to use an example to unpack this is posterior tibialis tendon dysfunction, stage 2 to 3. So the person starts with a medial deviated subtalar joint axis and a forefoot equinus, perhaps joints with greater mobility than normal. So because of these factors, we have substantial compensatory pronation occur on weight bearing, which overloads the midfoot joints, causing stiffness and subluxation through those joints and associated contracture of the tibialis anterior musculature, as well as other anterior compartment musculature, resulting in a forefoot supinatus adaptation. Now the compensatory pronation has to accommodate the forefoot supinatus as well, leading to maximal pronation. This increases the tension on the tibialis posterior tendon, which can reach a point of failure. So it's a cascading event. It's not just a once-off event, with the condition becoming worse as the body adapts to it. But foot dysfunction does not necessarily mean injury, but it may mean an increased risk of injury. As we know, running places high strain on tissues, combined with uneven surfaces, injuries do occur. And when you have on the left of your screen excessive pronation and on the right excessive supination, you can start to understand the at-risk behavior that's going on. So by using plantar pressure, we can quantify the risk and introduce treatments aimed at reducing that risk and then monitor their success. So if a person comes in who has the episodal inversion injury or episodal arch or medial ankle pain, and they run or they are involved in exercise, and they have this sort of poor function, even though they're not having an active injury process, we can say you are at risk. We can introduce strapping or taping or what have you, and monitor to see if that improves their risk status. So why use plantar pressure over visual gait analysis? Visual gait analysis can vary from looking at a person walk in a corridor to using a treadmill and video and slowing it down step by step. I want to separate assessment of the function of the foot versus structures proximal to the foot, such as the ankle, the knee, the hip, the back. In the foot, we are assessing the placement of the force applied to the foot. Above the foot, we're assessing the angular relationships between each segment and the ground. Let's have a look at a video. Let's just see what we see. What would be the foot posture index? Now, I'm sorry it's a bit blurry, but it's pretty clear to see that the feet are substantially pronated. We can see the too many toes sign there. We can see the forefoot abducting. We would agree that the foot is pronating substantially through the midfoot. When you're considering an orthotic correction, what would you do? Would it be to support the arch, stop the pronation? What would be your thought process here? But when we consider the force we're going through this patient's foot, we've got to say, well, where's the force from the patient's body weight being applied, and where's the ground reaction force being applied on the foot? So what we'll have a look now is the same video combined with plantar pressure analysis. And we can see on the outside, the trajectory of the body weight is through the lateral column because of its mechanical advantage and stability. If we added a really supportive orthotic designed to move the weight more laterally by lifting the arch, what would this do to the current loading of the plantar tissues from the weight bearing? It would push the weight bearing more laterally, making things worse, not better. Without plantar pressure analysis, we're left to make an assessment based on callus formation, shoe wear, and our best estimate. With plantar pressure analysis, we can actually see what's happening, try interventions, and review the outcome of that intervention. So who does force affect? Well, essentially anybody who stands. So it's not just for musculoskeletal patients. It is for any person who stands up and has got excessive loading throughout their foot. And some are very obvious, such as those with calluses, people with high risk diabetes or arthritis or neurological defects, of course, musculoskeletal pain, but also for rehab, pre and post surgery, and people who are at risk of falls. Our foot is an incredible piece of machinery, and I give a big call out to Kevin Kirby for this, the concept behind this slide, because it's basically based on his work. So the midfoot joint complex provides a paradoxical adaptive foundation that transforms the foot from a stable platform, from a mobile adaptive platform to a stable platform for the body to pivot over. Assisting this structure is a series of intrinsic musculature and ligament systems that work together to provide stability at initial contact, and an auto-supportive system to provide proper functioning through the foot as it leaves the ground. This has the effect of dorsiflexing the calcaneus and plantarflexing the medial column, thus stabilizing the arch shape. This is to restrain the effects of gravity through the skeletal structure, in this case through the tibia, the traction upwards pull of the Achilles tendon, and the ground reaction force affecting the rear foot and the forefoot. Now, these forces tend to have the opposite effect on the structure, that is plantarflexing the calcaneus and dorsiflexing the medial column. And it is a balance of these forces that are really, really important and will tell us whether the foot is going to function correctly or not. It is not really about how much the foot pronates. It is these forces interacting on each other and the body's ability to manage these forces. The most simple, quick and easy objective assessment for achieving this data of plantar pressure that can be easily compared against is a 2-minute recording of your patient walking over a mat and then spending 3 minutes analysing that recording. Not only does this provide us with a weight-bearing normal movement pattern, but also the key indices that we use to better understand the areas of dysfunction that needs to be addressed. These can all be measured against in the future to see whether our treatment strategy has been successful, all in 5 minutes. This is the pressure analysis window for the mat-based system, which I'll use to explain the major analysis tools. The mat analysis window provides us with our analysis dashboard containing the pressure mapping, the mapping of the color palette representing the loading of the footprints, offering average, peak, and integral views, the center of pressure trajectory and timing, the pressure versus time graph, including up to 5 regions of the foot or more in some software, and information on the 4 rockers of the foot. The Sensor Medica FreeStep software provides these 3 data sets when we select one of the pressure views. This example is using the data of a diabetic patient's recording walking over the mat. On the left, we can see the software gives us an average pressure of the feet from the data set. The average pressure view is made up from a combination of maximal pressure or peak pressure and integral pressure, which is timing. But even more importantly for the high-risk foot, it also gives us 2 key data sets. That is the maximum pressure or peak pressure, which is the middle data set, which shows the direct loading of the tissues, which we know from research has to be less than 200 kPa, preferably between 170 and 200 kPa. The other key data set is the integral pressure. That is the period of time that the tissue is loading. This is crucial with patients with high-risk feet because of an extended period of time the pressure is acting upon the tissues, pushes the blood from the tissue and can result in a localized hypoxemia, further damaging the involved tissues. It is this view, the pressure mapping colors of the integral pressure view, relate to the timing of the pressure, not the amount of the pressure. The center of pressure line not only shows us the trajectory of the body weight as it passes through the foot, but where there are blockages to forward progression. The ideal shape is being defined as the weight bearing being initially lateral, which has been defined as low gear. Then as it moves forward through the foot, it moves medially across to what has been defined as high gear across the parabola of the metatarsals. This has been described by Bojan Mola in his research. The center of pressure is an average between the body weight being pressed into the ground due to gravity and the resultant ground reaction forces returning into the foot. This white line should ideally be long continuous segments indicating a fluid pathway of body weight through the foot. Sometimes there are disruptions to this line, which are described as hesitations, minor blockages, and major blockages, where the forces are stopped or slowed down because of joint and soft tissue dysfunction. If we have a look at the left foot now, we can see the white line coming up, and it comes fairly fluidly into the forefoot, but it then slows right down, and you'll note that then speeds up again, but then it'll come to a direct stop, and it'll actually come back on itself as the weight reshifts through the forefoot and then forward again. Now, while this is happening, the trunk is moving across the body. So there has to be compensations through the lumbar spine, the hips, the knees, and the ankles to absorb this sagittal motion as this blockage occurs. And this is one of the key things we look for when a person presents with knee, hip, or lumbar spine pain, if there is such a blockage as we can see on the left foot. Let's look at the pressure versus time graphs, which are often referred to as force versus time graphs. But as pressure mats, treadmills and insoles can only measure vertical force, which is referred to as pressure, I think pressure versus time graphs are more accurate. The rear foot and forefoot loading curves, the green and the blue, should be sinusoidal in shape and symmetrical, indicating similar intensity of loading for approximately 50% of the stance phase. We can see in this particular graph that the top graph representing the left foot shows greater intensity of weight bearing in the forefoot than in the rear foot. Interestingly, the shape of the graph also tells us things. We can see in the lower graph, indicating the right foot function, a plateau in the green pathway, indicating substantial midfoot and forefoot dysfunction, blocking the pathway and not allowing normal transmission to occur. This is followed by a sharp onloading peak as the weight-bearing trajectory travels through the second MTP joint. This sudden increase in loading is exactly how tissues become injured, or at the very least places the person in a significant risk of future re-injury. The key here is not only to offload the second MTP joint, but also address the midfoot and forefoot dysfunction, so this abnormal loading does not occur in the first place. All right. So now we'll put this together to look at examples where using these tools helps our understanding. The first example will show the difference between a compensated and non-compensated forefoot supinatus presentation. Here we see with a compensated forefoot supinatus, the pressure mapping shows the weight traveling from initial contact of the heel straight through this third metatarsal through its MTP joint, moving through the second MTP joint with some slight weight bearing through the first MTP joint, exiting out of the IPJ of the hallux. The center of pressure line is straight from the heel to the MTP joints, indicating extreme dysfunction of the midfoot and rear foot joint complexes, the auto-supportive mechanisms and the muscles involved. There are also substantial blockages in the forefoot, more in the left foot than the right. Not surprisingly, the pressure versus time graphs show less weight bearing and intensity and timing in the rear foot than the forefoot, as the forefoot compensates for the structural misalignments and the adaptations that make up the flexible forefoot supinatus. If we now look at a non-compensated forefoot supinatus in the right foot, we can see, because there's not enough range of motion nor power in the peroneus longus, also perhaps because of a contracted tibialis anterior, there is not the weight bearing moving from lateral column onto the medial column, rather it stays on the lateral column. The pressure mapping shows consistent loading along this lateral column, with the IPJ and the hallux of the toes being plantar flexed and weight bearing due to the gross instability. There is no weight bearing underneath the first MTP joint, probably because it's dorsiflexed, explaining the high loading under the second to fourth MTP joints. Here we can start to understand that unless there is some arthritic joint deterioration, if we can correct this by soft tissue work, by joint mobilization, we should look at doing this first and then working through an orthotic correction as a secondary thing. Here's another example when we can use a set of tools to quantify if there's a leg length difference present. The global view of the pressure map, which you can see now, shows increased loading along the lateral column and forefoot of the left foot, where the opposite is the case on the right foot. The center of pressure also, not surprisingly, is lateral on the left foot and medial on the right foot. This may give us a hypothesis that the right leg is functioning as the longer leg. But how confident can we be of this? Perhaps there are other reasons for this pressure distribution, so we need to look at other evidence to support our hypothesis. Looking then at the pressure versus time graph, we can see that there's an increased intensity of loading for a long period of time in the left forefoot. Analysis of the right foot also shows us the reverse, where there is an increased timing and intensity of the loading in the rear foot. Looking at the timing of the weight bearing, we can see that the weight bearing moves through the trajectory progressively through the foot. We can see from initial contact to terminal stance that the weight bearing quickly moves along its trajectory in the left foot with an early heel lift, further supporting the hypothesis that the left is functioning as a shorter leg. So this just gives us various objective clues to support our hypothesis so we can move forward in a proposed treatment plan. So that was the mat system. We can actually also use treadmills with plantar pressure plates to pick up similar information. Of course, with treadmills, we can also see a person running as well as walking. So here we can see a video of a person running on the treadmill, and we can see that the weight bearing is very, very lateral, and there is significant loading affecting the fourth and fifth metatarsals, remaining there for most of the stance period. We see that the forefoot supinatus is limiting the medial column loading. So it's mostly through the IPJ of the hallux that the weight bearing finally exits the foot. We can also view asymmetries in gait using this sort of information to help us build our diagnostic hypothesis. To show further analysis of the treadmill, I'll use a walking gait analysis example. It's exactly the same for running gait, but you can see more information being presented. And here we can see the weight bearing going through the treadmill. We can see it as a 2D, or we can change it to be a 3D to give us a bird's eye impression to see not only the areas of loading, but their intensity as well. We can see the butterfly effect, we can have graphs. All of this information can be used to come up with the appropriate diagnostic information for us to make some decisions on. And once we have done that, what we can do is we can put some taping on or padding on, and then reassess the patient and do a comparison of how those interventions are making a difference. Of course, we can use video, and we can draw lines on the video, we can do analysis, we can look at the pressure versus time graphs coming across. All of this information is all objective, giving you key information to know what you're going to base your work on. Many companies, including Medica, have in-shoe systems, which are really good at seeing how orthotics or footwear is having an effect on the forces being directed onto the foot. This is where, if you are doing high-risk work or work where orthotics were key in offloading pressure areas such as in rheumatoid arthritis or other connective tissue disorders, this would tell you exactly where the forces were going and how the orthotics were actually affecting those forces. And we can look at forces in a varying ways, looking at kilograms per centimetre squared, kPAs, and newtons per centimetre squared. So it gives us a whole further window of information of what we can gain from the software, from the data, to make up our orthotics. Because essentially, this is what we're trying to do. We're trying to create a hypothesis. We're trying to create an understanding of whether that hypothesis is true, how we can intervene, and what we need to do to intervene. And in this case, as an orthotic design. So The plantar pressure equipment tells us what's happening, and that's unique because it gives us an understanding of the forces acting on the foot from the time of initial contact to the time of pre-swing, but it doesn't tell us why. It'll give us an indication of joint dysfunction, but not as if it's through arthritis or pain or biomechanical dysfunction such as functional hallux limitus. It'll show us asymmetry of loading between the rear foot and forefoot, but it won't tell us whether that's weakness and tightness of muscles, whether it's a lack of ankle dorsiflexion or an Achilles injury. And so what we still need to do is we need to do our weight-bearing assessment to start bringing out this information so we can make sense of it, so we can design the features we need to in our orthotics. So there's a number of different non-weight bearing and weight bearing assessments we need to do, and I'll just run through a few of them, which I'm sure we're all doing. So this is looking at the functional hallux limitus point and the release point, where as the name suggests, the functional hallux limitus ceases to have an effect on the foot. Of course, marking the subtalar joint axis to know where we need to place our inversion forces and eversion forces. In weight bearing, looking at resupination to work on what sort of material we need to resupinate the foot, whether it's a soft material for a lateral subtalar joint axis or a very firm material from a very firm subtalar joint resupination assessment. And looking at the Herbesheim maneuver or Jack's test to understand the orthotic corrections, especially in the midfoot and forefoot, to achieve easy and immediate windlass initiation. And we should look for the effort based on the frontal plane correction and the timing of the initiation of the windlass in the sagittal plane. So how would this look in a patient in our clinic? Well, let's consider a patient with heel pain in the left foot that's been present for some months. She has got some pronation that she's had an off-the-shelf orthotic to help with. That's helped a little bit, but not much. She's been working with some exercises the physical therapist has prescribed her, and this really has helped, but has not solved the problem. So I recorded her gait over our 3-step pressure mat, and after ensuring good data and averaging her footsteps, analysis was done to show the level of dysfunction of the left foot. By selecting the curves view and just having a look at the rear foot and first metatarsal phalangeal joint loading graphs, we can see the elongation of the arch and thus the strain on the plantar soft tissues. Here you can see the foot timing. It's very small, I know. On the left is 307 milliseconds, and on the right is 221 milliseconds. So to test our clinical hypothesis that the condition is from the arch elongating repeatedly and therefore re-injuring the plantar soft tissues, I applied sports taping to the foot to stabilize the medial column, preventing it from elongating. We then recorded her gait again and compared the difference. And we can see the timing now on the left foot is 144, which is less than half of the previous time period. I presented this to the patient, explaining its relevance, and based on the outcome that she could see, was very confident in a successful resolution of her heel pain. And she was very keen to go ahead with this because she could see the objective improvement. So we then did a scan of using a 2D, 3D scanner, and I do a partial weight bearing scan because what I'm looking for is a functional corrective type of orthotic. And when I say functional corrective, I mean that I'm correcting the weight trajectory through the foot so it's in the right place at the right time, and the auto-supportive mechanisms are working correctly. That's what I define a corrective functional orthotic. So from this, I get to see that the subtalar joint axis, which I've marked on the 2D picture on the left, I also see the functional hallux limitus release point, and I've got the 3D model for the design of the orthotics. And so what I'm going to do now is design up a pair of orthotics so you can see how we do this. So getting all of the information that we've gathered from the examination, from the plantar pressure data and the scanning, and of course the patient's history and their goals, we put that all together and put together a prescription of what we're trying to achieve with these orthotics. So let's go through. What we've done is I've got a base of the orthotic, and then I'm going to start putting the corrections on. So we know what type of material and correction design the orthotic needs to be made of. We know the corrective features we need to add to this platform to assist the foot to function, to work correctly. So we've overlaid our pressure mapping. We note that we need to do a cutout because the first metatarsal phalangeal joint would be blocked by the piece of material in the arch. So I'm going to select around the great toe joint, so to make sure there is nothing stopping that first MTP joint from weight bearing. And then I'm going to select a particular thickness, and then I apply that. And so now we can see there's nothing blocking that. And so now I've just smoothed that adjustment out. So the next thing I'm going to do is look at the functional hallux limitus point. So I'm going to put over the 2D picture, and I can see that that's the functional release point I've marked. So now I'm going to reduce the area distal to that point of the orthotic, because any part of the orthotic that's pushing up distal to that point is going to cause functional hallux limitus. So I need to reduce that point. So again, I mark that area as such. Okay, and I'm going to now reduce the volume of that area. Just a bit of housekeeping there just to make it a bit more nice. Good. And I'm going to reduce the volume of that area. And you'll see it shrink down when I do so, like that. And I'll just get that in a more smooth situation. I'll apply that again. Smooth the line. I know it looks a bit jagged at the moment. Okay, so now it's got that slope, and that's to what we refer in Australia as a cutaway, to allow the first metatarsal to plantar flex without any functional hallux limitus occurring. Now we've got to put a curvy skive on the heel to invert the heel, like we did with our taping. So again, I select that area. Okay, so here I'm selecting using the line from the 2D. So selecting that area to make a shelf. And now what I'll do is, using that area, I'll go into the wedge tool. You can see the area that I've selected on the 3D model. So I'm going to make a shelf, an inversion shelf at that point. So I'll go into the wedge model, and I will select a degree of inversion correction. I'll apply that, and now you can see that the slope has been applied to the model. Now that's to address the medial subtalar joint axis. Now, in this particular case, I really want to focus. My aim is to get the medial weight bearing, the medial column weight bearing better, and the first MTP joint more stable. So part of that is I want to dorsiflex the second, third, and fourth metatarsals, allowing the first metatarsal to plantar flex. And I'll use a small metatarsal dome to achieve this. I also noted that there was a very prominent plantar fascial slip on the medial column. So I'm now going to put a plantar fascial groove there. And again, we just reduce the material under that area, like so. And like with all orthotic modifications, you want to get it absolutely perfect. So that's done. And the last thing we're going to do, so there's the groove there, nicely shown. And the last thing we're going to do is, I'm being a bit pedantic here, sorry. Okay, that's just smoothing it out into the heel cup. That's great. The last thing we're going to do is to assist the timing of the initiation of the windlass. We're going to preload the hallux using a Cluffy wedge. This is going to lift up the hallux by about 4 millimeters, 4.5 millimeters, and so that as the foot comes forward, it's actually further assisting the hallux to lift up, which is plantar flexing the first MTP joint into the material. And that's the finished orthotic. It has a lot of correction in it, all based on our examination, and we can be quite confident that this is going to work well. Once we have designed our orthotic, it can be milled out with a very high degree of accuracy using materials as soft as latex through to very, very firm EVAs with a similar density of polypropylene. Using a mill like this makes the process accurate, repeatable, so that if the patient wants a second pair, it's a very easy job to do so. So if you're interested in what I've said so far, coming up in May, in fact, this Friday night, I'm running a 4-session webinar course. So I've sort of gone through a little bit of the first 2 features here, but on a very, very skimming the surface. The webinars are approximately 60 minutes to 90 minutes, depending on the content, so it's very content rich. You will have this placed on a learning dashboard, so even if you can't make the actual event, you have it replaying, the replays forever on the dashboard, so you can go back and review. And that's something that's really helpful. So you almost have an information hub for yourself. We provide worksheets, and we also provide a one-on-one session so that we can go through any information specific to your clinic, such as setup, protocols, training, and so on. So this webinar is normally $200 US, which is only $50 per 90-minute session. But for this webinar, we've put in a 15% discount, so it's only $170. Now, unfortunately, my assistant tells me that the website is wrong, so she's put it in the chat. So it's actually www.stepforce.com. If you are interested, as it starts on this Friday, please don't lose time. Please join up as soon as you can. And I can tell you, if you have plantar pressure equipment or you're considering plantar pressure equipment, it's really going to be worthwhile for you to have this information. It's essentially the last 20-something years of my learning, and I just wish I had it back in 1987, 88. It would have made my life so much easier, and I'd just be so much further advanced. So that's my presentation. Let me come back to the webinar, Jan. Okay, so I'm really happy to answer any questions that you might have. So, Dr. King, has there been any questions?
Yep, we got very, very fascinating, Paul. I mean, you've obviously forgotten much more biomechanics than I ever even knew, first of all. And, it's interesting. I think that a lot of us that were surgically based don't take a lot of that into account. Just look at techniques and you do IM angles and angled angles and you name it, whatever it is, by X-ray, and you do a procedure, right? But you don't take into account those sorts of load forces that really can make or break your surgical procedure as well.
Yeah.
So I'm just going to put this behind us and then we can chat. So I got a couple of questions. So we have a family in our community that has Charcot-Marie tooth, but not the whole family. Would your sensor plate help us diagnose that at an early age?
That's a really good question. It's not a very easy question to answer because what you're looking for is nuances that may indicate dysfunction. So the short answer is yes, because what we know, of course, with CMT, the midfoot basically self-destructs. And with a person with CMT, they have very short loading in the heel, very increased both in timing and intensity of loading in the midfoot, and again, very short loading in the forefoot. So if you had a person who had a family history of CMT, having them walk over a pressure measuring device every 12 months and just looking at the loading curves, the pressure versus time curves, and looking at where the pressure is being loaded and the timing of that loading would give you a nuance that the foot is not functioning properly. If we go back to the slide where I talked about the midfoot and the ligaments underneath the midfoot and the muscles underneath the midfoot, they start to become neuropathically affected. So they're not working, the muscles are not working properly. So therefore we see the changes in the midfoot function first. The foot flattens out. We see, and normally with a flattening of the arch, you don't see much weight bearing through the arch at all, and you still see the majority of weight bearing from the heel to the forefoot. But as the CMT dysfunction starts, you would see more weight bearing into the arch and for a longer period of time. And that would be the predictor. Now, of course, you'd take regular x-rays to assess the joints and other assessments as well. But it's the timing and the intensity of loading through the midfoot, which would be a predictor. And the good thing about plantar pressure is, of course, you can compare 1 year to another or one visit to another, both in the timing of that loading and the intensity of that loading.
About how long does it take for you to perform your typical analysis, Paul?
For a new patient, where I go through the history, I go through their goals, I go through a non-weight bearing and weight bearing assessment, a pressure analysis like you've seen today, and a treatment plan is 40 minutes.
Oh, that's pretty good. Okay.
And
so
that provides me a treatment plan. That may mean then I get them back for mobilization or exercise programs, or I might do some taping for them to trial or something. So it does usually have a small amount of treatment to justify my fee, but it's mostly diagnostic to get an understanding where we're going or where I have to refer them to.
Makes sense. So would you recommend that people changing their orthotics from their working shoes to their exercising shoes to maybe their ski boots? I mean, ski boots are a little bit unique in themselves, but would you recommend that people have different types of devices for different?
Okay, that's a really good question. It really depends on what their work shoes are like and what sort of exercising they do. Normally, if a person just has a normal sort of footwear and their exercising is relatively low loading, e.g. walking around as their main sport, or maybe some weights at the gym, I think you can get away with just the one design of orthotics. However, it really is dependent on the loading that is being applied to the foot and the footwear, which makes up part of the orthotic, as how it affects the loading of the foot. If the person has a more narrow dress shoe and they do pump classes to keep the body beautiful, then obviously the orthotic that they've got in their shoe is not going to be able to withstand the forces of a pump class where they're jumping up and down off a step. Similarly, if you are a person who does running and you are a keen golfer, the orthotics that have got the corrective features and materials that are appropriate for your running gait may be too corrective for you to have the flexibility of a swing in golf. So you may have to modify it for that. So I'd say it's not a blanket rule, it's a subject-specific rule.
That makes sense. So do the orthotics made from the sensor treadmill differ from the typical two-step plates or non-weight-bearing 3D scanning that people are using?
No. Short answer is no. The plantar pressure is the same. There is a difference that with a treadmill, the analysis is a slightly different way to understand it, because with the mats and the in-shoe systems, you are walking over the ground, where on a treadmill, the ground is going from underneath your foot. So the actual way the pressure mapping is designed is slightly different. But once you've done the analysis, you then go on to make the orthotics is exactly the same.
Very good. So this one's interesting. Would you recommend someone with a drop foot deformity and a steppage type of gait to have an extra cushion support beneath the metatarsal heads? I mean, I guess that's assuming they're not in an AFO, but
if a person, well, certainly if a person has got a foot drop, that means that they're loading huge amounts of weight on their forefoot, and so that the forefoot is the initial point of contact to the time when the person pivots and steps off the foot, then yes, we'd need to somehow move those forces and redistribute those forces substantially. But as you said, what we would want to do is try and get the weight bearing off the forefoot and more onto the rear foot. So some sort of an AFO or brace that goes from the anterior ankle to the laces of the shoe to hold the foot in a slightly dorsiflexed position may be more effective than just putting padding where the loading is there anyway. Certainly, you would still do the padding perhaps, but the key thing is if the tissues are being loaded for 90% of the stance phase, changing that period of loading so that you alter it so it's only loading for 30% of the stance phase and you're removing the rest onto the rear foot is going to make a bigger effect on the loading than just the soft material.
Excellent. So we came from the era where we were trained with rotodor orthotics, as I'm sure you remember very well, the rigid type. There are all sorts of crazy versions, from the rigid to the semi to the soft to whatever. You can go on Amazon, sadly, and buy most of them. But what's really, I guess, I was always taught one was structural and one was functional and all these different terminologies. But what's the real difference between, say, that rigid rotodor orthotic and the new milled, softer EVA types our patients all seem to love? Okay, so this is where I'm going to get myself into trouble. So a disclaimer, we all have different perspectives, and all I'm doing is talking from the research. Rotodor was just before me. I can remember seeing them, and I can remember looking at them and looking on them as in awe of how beautiful they looked, how shiny and perfect and flawless, and they were just gorgeous. That was back in a time whereby the whole focus of our
treatment strategy was to stop excessive pronation. We were to try and stop movement. Now, if you try and stop movement of a person over 20 kilograms, that's a really big ask to do. So you needed something really hard to stop that pronation. And remember that the paradigm of the Russian paradigm was all you had to do is stop the pronation up to the point of mid-stance, and then after mid-stance, everything would work perfectly. So that's the reason why the rigid type of orthotics were born, and that has continued on. But in 2003 and 2006 again, Maclay, Winter et al. Did research to show that the way orthotics work is not by altering the rear foot eversion position, or substantially at least. They had, if my memory serves me correct, in the 2006 study, they had 15 or 16 subjects, and on a minority, they could only see a 1 degree difference with the orthotic, but they found that there was a 70% reduction in the effort to invert the foot. So how the orthotics were affecting the foot was by making it easier for the foot to invert, taking the loading off the structures that made the rear foot invert. So for a start, we didn't really need to have something rigid. All we needed to do is, rather than stop movement, we needed to have to change the direction of that movement, to facilitate, to use Howard Dannenberg's term, the changing of the direction of the movement, how it moved through the foot. So the way that the foot was designed to take the weight was the way its weight was being placed on it. In that case, you don't need something super rigid like Roeder. But the question then came, well, how much do you need? And that depends on how much effort it takes to resupinate the foot, where the subtalar joint axis is, what the BMI of the patient is, what is their proximal structures like in the foot, above the foot, and if they have pain, and all sorts of other key indices that help us make this decision. So for example, if you've got a 120 kilogram patient, but they've got a very lateral subtalar joint axis, and you put a very hard material underneath that foot, they will supinate, or they will have an inversion injury, because the axis for the subtalar joint is very lateral. So going through these examination techniques of subtalar joint axis, Jack's test, resupination, etc., gives us a bit of an understanding of what type of orthotic material is best for the individual patient, and then we can then slightly change that. If, for example, that 120 kilogram person starts doing distance marathon, we might have to alter the material because based on the changes in the loading of him running.
That's excellent. Well, Paul, this was very informative, very interesting. It's something I think a lot of us don't think about as much as we should, as I noted earlier, especially as we've become very surgically oriented, especially in the U.S. But it was very informative. I appreciate the time. I think that Sensor Medica may become a partner with Taylor sometime soon. I guess there are some talks going on, but we're delighted to have you. I really very much appreciate. We all thank you much for your time, and I'm glad we didn't have to get you out of bed at 3:30 in the morning for a change. But now you're already a day ahead, so you can tell me what's going to happen tomorrow. So there you go. So
well, I can tell you it's a beautiful sunny day in Geelong, Victoria, Australia.
Wonderful, lovely. We want to thank all of you for being here, and our next Taylor Tuesday is May 18th, and we're tickled to have also former APMA President Joe Camparuso, as well as Jesse Villarreal from Pelly Skin to talk about their product Smooth AF. I always tease Dr. Camparuso about what the AF is, but it's really alcohol-free. So, but instead of using social media lingo, AF. But anyway, we thank all of you. Again, Dr. Graham, thank you very much. It's been a pleasure. and especially all the fun name dropping, Kevin Kirby and Howard Dannenberg, all our good old colleagues, which we love. So everyone, thank you very much. Thank you, Paul. And thank you to the Taylor team for putting this together and all of you to be here. And we look forward to seeing you in 2 weeks. Have a great night. And Paul, you have a great day.
Thank you. Bye.